Compared to other areas of the nervous system, the peripheral nerves seem pretty simple, don't they? Which is great. So we talked about just basically about the peripheral nerves, and now we have to talk about dysfunction in the peripheral nerves. So the learning objectives for this is we're going to talk about different types of neuropathies, mononeuropathies, multiple mononeuropathies, and polyneuropathies. And we're going to talk about examples of each one. We're going to talk specifically about carpal tunnel syndrome, which is a mononeuropathy, and the signs, symptoms, and pathology and etiology for carpal tunnel syndrome and the treatment. Fun, right? So, signs of peripheral nerve damage include sensory, autonomic, and motor changes. Because we have sensory, autonomic, and motor axons in all the periphery nerves, all the signs, all the sensory, autonomic, and motor signs of dysfunction are present in a peripheral nerve distribution. So we're going to keep going back to that. It's not going to be in a dermatomal distribution. It's not going to be a myotomal distribution. So dermatomal would be sensory only. Myotomal would be motor only. Autonomic would be autonomic only, but you're going to get all of them. So sensory changes include decreased or lost sensation and or abnormal sensations. So hyperalgesia, dysesthesia, paresthesia, and allodynia. Remember, we talked about those in chapter 12. So hyperalgesia is an extra sensitivity. Dysesthesia is painful abnormal sensation. Paresthesia is painless abnormal sensation. So that's usually that zinging or electrical sensation. And allodynia is a painful reaction to a stimulus that wouldn't ordinarily be painful. So just as a reminder from chapter 12. The autonomic changes are going to depend on the pattern of axonal dysfunction. So if a single nerve is damaged, autonomic signs are usually observed only if the nerve is completely severed. So if some information is getting through, you're not necessarily going to get autonomic signs. The autonomic signs include things having to do with sweating. So lack of sweating, loss of sympathetic control in smooth fibers and arterial walls is what causes the lack of sweating. And that can contribute to edema in an affected limb. If a lot of nerves are involved, autonomic problems can include all sorts of circulatory things, bowel and bladder functions, dysfunction, impotence, difficulty regulating blood pressure, heart rate, sweating, lots of issues. So the more nerves involved, the more autonomic issues are going to show up. Hopefully that makes sense. So the motor changes, I don't have a slide for motor changes, but maybe I'll put one in later. The motor signs of peripheral nerve damage include paresis, which is weakness, or paralysis, which is just no function in the muscle. If the muscle is completely denervated, and they do an electromyogram, the recordings will show no activity for a week, approximately a week following the injury. So muscle atrophy progresses rapidly because once you lose that neural connection, the muscle's like, I don't need to do anything. I'm not getting any neural input. So the muscle fibers begin to develop after a week after an injury. They develop a generalized sensitivity to acetylcholine along the entire muscle membrane, not just at the neuromuscular junction. And that causes the muscle to fibrillate. That's that twitching. Fibrillation is a spontaneous contraction of individual muscle fibers, and it's observable only with an EMG. You can't see it to the naked eye. Fasciculation is a visible quick twitch of muscle fibers, but fibrillation is happening on a smaller level, and can't be observed on the skin surface. So fibrillation is always abnormal, but it's not diagnostic of a specific lesion. So it doesn't, just because you have fibrillation doesn't mean you have a particular lesion going on. So when a nerve supply is interrupted, trophic changes begin in the denervated tissues. So by trophic changes, we mean changes in the skin and connective tissue in the area. So the damaged nerve is not providing nutritional factors to the target tissues, and we're not getting any electrical potentials. So we see changes in the soft tissue and connective tissue in the area. So trophic changes include muscle atrophy, shiny skin, brittle nails, thickening of subcutaneous tissues, ulceration of subcutaneous tissues and cutaneous tissues, poor healing of wounds and infections, and neurogenic joint damage can all happen secondary to blood supply changes. You could also get loss of sensation and lack of movement. So when a tissue is denervated, a lot of things are affected, not just the muscle, but all the tissues in the area. So when we talk about complex regional pain syndrome, you see trophic changes in complex regional pain syndrome. So there's obviously something going on in the nervous system with that. And trophic changes are common, or complex regional pain syndrome is common with crush injuries, and that makes sense. There's a lot of nerve damage with a crush injury, and we'll talk about the different types of nerve damage. So in classifying the different neuropathies, we're either they involve a single nerve, several nerves, or a whole lot of nerves. So mononeuropathies, such as carpal tunnel syndrome, involve a single nerve. Multiple mononeuropathies involve several nerves, or polyneuropathies involve like lots of nerves, like multiple nerves. So the main difference between a multiple mononeuropathy and a polyneuropathy. So mononeuropathy is focal dysfunction. So just that one area is affected. Multiple mononeuropathy is multifocal. So you might have things going on asymmetrically throughout the body. Polyneuropathy is a generalized disorder that typically presents symmetrically, and it starts distally and moves proximally. So the dysfunction can be due to damage to axons, damage to myelin sheaths, or both. So there's a table in the book that summarizes table 18.1, the peripheral neuropathies. And so the way that we're distinguishing between them is a single nerve, it's a mononeuropathy. If it's multiple nerves, asymmetrical presentation is usually a multiple mononeuropathy. So lots of different foci. Polyneuropathy is symmetrical, and it starts distally and moves proximally. So a mononeuropathy, a good example of a mononeuropathy is traumatic injury to a peripheral nerve. So there are lots of different types of trauma that can injure peripheral nerves. Depending on the severity of the damage, traumatic injuries to peripheral nerves are classified into 3 different categories. So the 3 categories are traumatic myelinopathy. So some trauma happens to the myelin. Traumatic axonopathy. Can't say that word. Axonopathy. So something happens to the axon, or complete severance. So myelin and the axon get axed in that one. So with a traumatic myelinopathy, that is the loss of myelin limited to the site of injury. The peripheral myelinopathies interfere with the function of both large and small diameter axons, and myelinopathy of large diameter axons causes motor, light touch, proprioceptive, and phasic stretch deficits. Makes sense, right? Because those are the things that travel on large diameter axons. The effect on small diameter axons includes impairment or loss of nociceptive and temperature sensations, and generation of neuropathic pain. Now, doesn't that make sense based on what we talked about in the vertical systems and what is carried on what size nerves? So it's all coming together. Isn't that nice? So unless the injury is unusually severe, you usually still have some autonomic function, which, that's nice because the autonomic nervous system is more body-wide instead of being running along an individual nerve. So there's still information getting through on the autonomic nervous system. And we'll see that when we talk about the spinal region too. With some spinal cord injuries, there's still some communication in the autonomic system. So axons aren't damaged with myelopathy. If the axons are damaged, then it's the axonopathy. So recovering from traumatic myelopathy tends to be complete because remyelination can occur rapidly. So you don't get irreversible damage in the target tissues. So focal compression of a peripheral nerve can cause traumatic myelopathy, and carpal tunnel syndrome is a good example of this. So repeated mechanical stimuli like excessive pressure, stretch, vibration, and or friction may cause focal compression. And there's a sequence of events that follows that produces that traumatic myelopathy. So the nerve compression decreases axonal transport and blood flow in the epineurium. Decreased blood flow causes edema of the connective tissue. Edema further restricts blood flow and axoplasmic flow that interferes with axon function, despite the axon being physically intact. The connective tissue thickens and develops scar tissue and causes myelin damage. And the myelin damage causes neuroinflammation. And the neuroinflammation sensitizes connective tissue. This sounds like a bad pathway. So signals from the myelin deficient part of the nerve can produce pain, and decrease nerve conduction velocity because we lost myelination, right? So that's a kind of a big problem. The most common one that we see is carpal tunnel syndrome. So it's compression of the median nerve in the space between the carpal bones and the flexor retinaculum. So, or the transverse carpal ligament. So that causes the traumatic myelopathy in the pathway that we just talked about. So if you have a job, like say that you work in a machine shop and you're always, or some kind of shop and you're always using a router, so you're holding on to a vibrating tool, that can cause that. If you have a repetitive job where you're doing the same motion over and over with gripping. So carpal tunnel syndrome is more prevalent in people whose occupations it require working in a cold environment or gripping vibrating tools or doing repetitive things like grocery checkers or something like that, where you're doing the same action over and over and over again. So it's really interesting. In carpal tunnel syndrome, the diameter of the median nerve can actually be enlarged because of that neuroinflammation and the connective tissue edema. So you get that thickening, scarring, and inflammation, and that can spread from the site of the lesion to the dorsal horn of the spinal cord. So very interesting that something so small can, spread all the way to the spinal cord. When we get into traumatic axonopathy, so instead of myelopathy, now we're getting into the axonopathy. The axon is disrupted, but the myelin is intact. So with the traumatic myelopathy, the axon is intact, but the myelin is disrupted. With axonopathy, it's just the opposite. So you get degeneration, Wallerian degeneration, which is one of the things that kills off nerve cells, distal to the lesion, and axonopathies can affect all sizes of axons. So it can affect reflexes, somatosensation, and motor functions. Those, because anything distal to the area of injury is going to degenerate. Axons are able to regenerate in the peripheral nervous system and reinnervate the appropriate targets because the myelin and connective tissues are intact, and that sort of gives the nerve a little pathway to grow along, which that's super cool. So that's why you get regeneration from peripheral nerve injuries and traumatic axonopathy a lot more easily than you get healing of other type of nerve injuries. So it's nice to know that you can recover from these pretty easily. When you get complete severance of the nerve's physically divided by excessive stretch or laceration. So the axons and the connective tissues are completely interrupted. And that causes immediate loss of sensation and or muscle paralysis in the areas that the nerve supplies. So laceration, it could even be a surgical incision that causes that. When they do surgical incisions, they really try to avoid cutting motor nerves, but you get a lot of sensory nerve severance during a normal surgery. Um, if the proximal and distal nerve stumps are opposed, meaning they're like really close to each other, they're approximated, and you don't get a lot of scarring, you can get sprouts that are guided to their target tissue in the periphery. So again, you can get, even with complete nerve severance, you can get recovery. But remember from the neuroplasticity chapter that neurons recover at a rate of 1 millimeter per day. So you can get recovery, and if they're really close to each other, if the stumps are really close to each other, you get faster recovery because you don't have as far to grow, but it still takes time to recover from that. So multiple neuropathies involves two or more nerves in different parts of the body. So the individual nerves are affected, and you get a random asymmetrical presentation of signs. So it's almost like you have two or more mononeuropathies. So it's multiple mononeuropathies, if that makes sense. So it can be a metabolic issue like diabetes or vasculitis, which is inflammation of the blood vessels, causing ischemia of the nerves. Vasculitis causes multiple mononeuropathies by restricting blood flow or by weakening the vessel walls. So it can be that, or it could be a traumatic injury, but individual nerves are affected, and that's what produces the random asymmetrical presentation of signs, as opposed to polyneuropathies, which are their symmetrical involvement of sensory, motor, and autonomic axons. So a lot of times they progress from distal to proximal. That's the hallmark. They call it a sock and glove presentation. Makes sense, right? When you see the picture, like sock and glove. And it's both, it's bilateral. So the symptoms typically begin in the feet and then appear in the hands. And the reason that happens is because the feet and the hands are the areas of the body that are supplied by the longest axons. So the sometimes the sock and glove distribution that you see, you get degeneration of the distal part of the long axons because of inadequate axonal transport, making the distal axons more vulnerable to degradation. Demyelination is also likely to produce distal systems first because the longer axons have more myelin along their length, and they have a greater chance of being affected by the random destruction of myelin. So when you have severe polyneuropathy, the person lacks sensation, and so can be unaware of injury to an affected body part. So they could have like a sore or a wound on their foot and not know unless they visually inspect it. So the lack of awareness often leads to injury like skin ulcerations and neurogenic joint damage and poor healing in the affected part. So education, talking about inspecting feet and caring for the areas where they don't have sensation is really important. That's something that we can really do for our patients. So as opposed to mononeuropathies, polyneuropathies are not usually due to trauma or ischemia. The cause of polyneuropathies can be toxic or metabolic or autoimmune or even hereditary. So the most common causes of polyneuropathies are diabetes, nutritional deficiencies secondary to alcoholism, and autoimmune diseases. So there are lots of different medications, industrial chemicals, agricultural chemicals, and nutritional disorders that can cause polyneuropathy. So you're more likely to see people in the clinic with diabetic polyneuropathy and Guillain-Barré syndrome, which is an autoimmune disorder. And the good thing about Guillain-Barré, which I've worked with several people with Guillain-Barré, is they can recover from it significantly. Diabetic polyneuropathy, you're probably not going to recover from that. In diabetic polyneuropathy, the axon and the myelin are damaged. So, that's a bummer. You get decreased sensation along with pain. It just doesn't seem fair, right? So you you lose your somatosensory stuff, but you get to keep pain. That's not fair. Also, paresthesias and dysesthesias. Balance and strength training have been shown to reduce risk for falls in people with diabetic neuropathy. So gait and balance improve with exercise. So I'm always getting back to that, right? Exercise, it helps with a lot of different things. So there's tons of research to show that exercise is not going to make the neuropathy go away, but it does improve balance and reduce the risk for falls. So it's super, super important. Also, proper diabetic foot care is really important for avoiding other issues. So if someone who has diabetic polyneuropathy wears appropriate shoes, regularly inspects their feet, takes proper care of their skin and toenails, they can prevent limb amputations, which diabetic polyneuropathy is one of the most common causes of limb amputation. And we can reduce that a lot by educating our patients about appropriate footwear and proper care of their feet. So gait and balance training, that's our wheelhouse. Also patient education. I love it. But there is such a thing as idiopathic polyneuropathy, where older people without diabetes develop peripheral neuropathy. Among people over 60 with polyneuropathy, in 10 to 18% of them, there's no cause that can be identified. You just have it. Which, that's kind of a bummer, but there you go. And Guillain-Barré syndrome is a demyelinating polyneuropathy. It's characterized by more severe effects on the motor system than the sensory system. And paresis may be worse proximally. Um, Usually sensation is worse distally. The onset's usually rapid with progressive paralysis. Urgent diagnosis and treatment is required to prevent respiratory failure because it can affect the phrenic nerve. 1/3 of patients with Guillain-Barré syndrome require a ventilator during the acute stage to help you breathe until you recover enough to not have to have the ventilator. One time I worked with someone who was recovering from Guillain-Barré syndrome and actually had a really good recovery. And she just happened to be one of the people that had to be on a ventilator. She had the best attitude in the whole wide world. And I was working with her in outpatient. So she had been an inpatient, an ICU on a ventilator. She went to inpatient rehab and worked in there. And then she was working with us in outpatient. And she said, "Hey, any day that I wake up and I'm not on a ventilator is a good day." I'm like, okay, I like your attitude. So good attitude gets you a lot of points in my book. There are hereditary motor and sensory neuropathies. Um, sometimes they're called HMN, hereditary motor neuropathy, or CMT, Charcot-Marie tooth disease. And Charcot, you'll see a lot of neurological things named Charcot. He was a French neurologist in the 1800s who characterized a lot of these diseases. But Charcot-Marie and tooth were all neurologists that work together and characterize this particular disease. CMT or HMN, it usually causes paresis of muscles distal to the knee and results in foot drop, a steppage gait where you have to pick your knee up to advance your foot without dragging your toes, frequent tripping because of that, and muscle atrophy. Significant numbness is unusual, so it mostly affects motor issues. Therapy involves strengthening, stretching, conditioning, joint muscle and skin protection, gait and balance training, like everything. The stretching is really important for people with CMT. A lot of times they have to end up using some sort of assistive device, but that's not usually until much later in life. So a lot of people that have HMN or CMT, whichever one you want to call it, I hear both. They know they have it. They know it runs in their family, and they come into therapy. They're working on dealing with it the best they can, which is great. So the neuromuscular junction, there are some dysfunctions that can involve the neuromuscular junction. One of them we talked about in one of the early chapters, myasthenia gravis is an autoimmune disease that damages acetylcholine receptors at the neuromuscular junction. So every time you use a muscle, it gets weaker and weaker and weaker because the acetylcholine receptors are saturated and you don't have as many. So the muscles that you use a lot, like the muscles that blink your eyes and the postural muscles that hold you up, are the ones that are more affected in myasthenia gravis. It's treated medically with immune suppressant drugs. So usually the treatment's pretty well. A lot of times when you're working with someone in PT with myasthenia gravis, you're working on gait and balance training, you're working on posture, you're working on energy conservation, and just general patient education about the disorder. Botulism causes interference with the release of acetylcholine from the motor axon, or if you get Botox injections. So you can get the cosmetic injections that people get so they don't have wrinkles in their forehead. I love my forehead wrinkles, but whatever. Whatever. I'm not obsessed with looking young, but some people are. My forehead wrinkles are part of me. I choose to embrace them. But um, Botox injections can also be used for people that have spasticity after a stroke or people that have CP or something like that. So what the botulinum toxin actually does is it interferes with the release of acetylcholine from the motor axon. So if you're getting it cosmetically, it keeps your muscles from contracting. If you're getting it because you have muscle spasticity after an upper motor neuron problem, it decreases the spasticity in the muscles and makes it so you can move a little bit better. If you actually get botulism, like you didn't get Botox injected, it produces acute progressive weakness and loss of stretch reflexes, even though you still have sensation. So Botox specifically acts at the neuromuscular junction, so it doesn't have any effect on sensation. Myopathy are disorders that are intrinsic to muscles. So you get sensation and autonomic function remaining intact because the nervous system isn't affected. It's just the muscle. Coordination, muscle tone, and reflexes are unaffected until muscle atrophy becomes so severe that you can't elicit muscle activity. So even though it is not a nervous system disorder, it's usually included with that because you end up getting problems with muscle activity, like backflow from the myopathy, if you want to think of it that way. So the electrodiagnostic studies that they use are the EMGs, electromyograms, dysfunction of nerves and peripheral nerves and muscles are evaluated by EMGs. You actually use an electrode, pierce the skin, and get into the muscle and record the electrical activity from nerves and muscles. So nerve conduction studies are done on the surface to differentiate among different types of neuropathies. Electromyograms are done with electrodes that actually go into the muscle that measure the electrical activity in the nerves and muscles. So you find out different things from the different kinds of studies.